All right, take it away, Chelsea.
Thank you so much, Rebecca. Thank you, everyone, for being here. We are thrilled to have you, and hopefully, most of you are enjoying a bit of a reprieve from the heat that we've had over the last week or so. Wherever you are in the country, taking some nice deep breaths and enjoying not sweating through your clothes, as I know we all were last week, and staying safe. So, again, we're really excited that you're here. I'm Chelsea Cipriano. I'm the Executive Director of the Common Health Coalition. I'm joined by wonderful colleagues from Milbank Memorial Fund, Johns Hopkins School of Public Health, the Tennessee Department of Health, Northwest Healthcare Response Network, and others. And I'm just so excited to jump into this important topic of extreme heat. As I think many of you saw, we as a collective released this report last week or 2 weeks ago. Last week, I guess. What is time with a holiday in between? That really explores the cost of not preventing heat-related illness in this country. And it couldn't have been more timely, unfortunately. We did not plan that. But we really want to stress the importance of prevention and do so in terms and using lives, dollars, cents to do so for the many organizations that we all serve as membership orgs and partners. So we're talking to healthcare, to our friends in the employer community, to the broader economic impacts. If those of you listening are from an elected's office, we want everyone to understand that prevention upstream means lives saved, savings saved, money saved, and system strains saved downstream. And that's true for pretty much all of public health, right? For our public health friends on the call. But in particular, when it comes to incidents like extreme heat and the heat wave scenario that we'll walk through with Dr. Watson from Hopkins. So I believe that's it for my intro. And oh, sorry, I'm getting a note before I close. Yes, please submit questions in the chat. So please, throughout the speakers will submit questions. Our goal is to not speak too much at you and really get to the discussion. We have some great speakers lined up on this topic, and I know it's unfortunately top of mind for everyone right now. So let's jump into it. Deb, I think I'm passing it your way.
Yes, thank you so much, Chelsea. And I'm Deb Lubar. I'm the president of the Milbank Memorial Fund, and I've really loved having this collaboration with my colleagues at Common Health Coalition and Johns Hopkins University to lift up a really important public health and healthcare systems issue. If you go to the next slide, I just wanted to say this is who's talking. You'll see all of us in real life, so we can move on to the next slide. Here's our agenda. Like we said, we have plenty of time for panel discussion and audience questions. So please use that Q&A box throughout, and we'll be facilitating that at the end. Next slide. Just a word about the Milbank Memorial Fund. We are an endowed operating foundation that really focuses on state and local health policy. So you can see a little bit here about how our work is conducted. And I just wanted to say why we care about this issue, which is, first of all, emergency preparedness and response is so critical to population health and health equity, which is our mission. And it is the place where we can really learn how to collaborate together across systems. So heat is one of those emergencies that we know is coming. There are many emergencies that we haven't imagined yet or that will unfold in different ways, but we know that we need to be ready for this. So this was a really good opportunity for us to highlight actions that state health policy makers and healthcare systems leaders can be doing right now and throughout the year that will not only help prepare for heat emergencies, but for all the unexpected emergencies that are coming our way. We also see this as really important work across state agencies, and that's one of the things we do at Milbank is bring together state executive branch and legislative leaders who are thinking about Medicaid and healthcare regulation and public health and human services and behavioral health. So we're really excited to see the broad group of people that's here today, and I want to jump right into the content. Next slide. Chelsea?
Oh, this is me. Sorry. Yeah. Very quickly. So, for those who don't know us, hi, we're the Common Health Coalition. We are now 400 plus members strong of organizations across the country who are committed to working together between healthcare and public health to make a better system for people. So, if that resonates with you and your organization, your state, your hospital, your nonprofit, whatever you may be, academic institution or not already a member, it's free to join. We would love to have you. And we'll drop the website in the chat. But hi, that's us. Next slide.
Okay, I think that's me. Hi, I'm Crystal Watson. I'm the director of the SHIELD initiative at the Center for Health Security and an associate professor at the Bloomberg School of Public Health at Johns Hopkins. What I'll do, it has been a real pleasure working with the Common Health Coalition and Milbank Memorial Fund to think through what the cost would be for this type of scenario. And so what I'll do is take you through our analysis, and then I'll turn it over to some colleagues to talk about some real world perspectives. So first I'll start with our approach. Our team at Johns Hopkins approached this through a scenario model that looked at both the health and economic costs of a prolonged heat event in a state in the US. This is one example of how a heat emergency might play out, but it's based on data from the literature as well as narratives of events, accounts of events that have happened in the US and internationally. The model isn't intended to predict future events, but it's a helpful way to walk through the potential consequences that we might see and plausibly might see across many locations around the country. So what we wanted was to better understand what individuals and communities experience during a heat wave and explore the associated costs. And another purpose of the modeling was to help put preparedness, prevention, and response costs into perspective. While some of those costs are a little bit harder to define sometimes, the magnitude of the consequences, I think, is really helpful to illustrate the benefits of prevention and preparedness. Next slide. So now I'll get into the scenario. So what we did was try and capture some of the important elements of a heat emergency. So we chose a scenario that takes place in a US state, including a large metropolitan area over a 5-day time span. This mirrored some recent experiences, as Chelsea alluded to, and is consistent with the heat waves we've experienced in the past as well. In this heat wave that we're modeling, we have a very high temperatures that are around or even above 100 degrees Fahrenheit, which is compounded by humidity, and temperatures that remain high overnight, which really limits the relief that people get from the heat. And the prolonged nature of the heat puts strain on power grids, ultimately resulting in rolling brownouts, particularly affecting urban residents for 24 hours or more at a time. Of course, this results in many disruptions, including loss of air conditioning and functioning of home medical devices that many residents rely on. The healthcare system is obviously also affected, with hospitals forced to cancel some elective procedures because of reliance on backup power. Dialysis centers are also affected and can't provide their usual services due to power losses, just some examples of the impacts. And outside of the city, agricultural and other outdoor workers are hit very hard by both the heat itself and lost wages if they're forced to stop work. And we know that urban residents, particularly those who don't have good access to cool environments and those with pre-existing medical conditions and other medical needs, face really dangerous conditions. Okay, next slide. I'll go into the results. So now I'll talk about some of the health and economic impacts. Now that I've described our process and our scenario at a high level, you can definitely see more of the details on this if you go to our brief, and as well as the publication that we have up on medRxiv. The heat impacts in this model were very significant, with an estimated 300 deaths and 4,000 heat-related emergency department visits and hospitalizations. The drivers for these impacts include illnesses, both directly due to heat exposure and also exacerbations of chronic conditions like asthma and heart disease. People who are especially vulnerable were those who rely on medical devices or dialysis function to survive. Many of those individuals would receive care and be hospitalized, so we included that in the model. Also, a large range of other pre-existing conditions and different age groups are more vulnerable as well. And there are also long-term effects from delayed care because of the heat and loss of electricity, the canceled elective procedures that may have been urgently needed. The health system impacts we see are also very significant, totaling an estimated 48 million in medical system costs, including costs due to surge in emergency medical services and hospitalizations, as well as lost revenue from delayed and canceled care. And lastly, but of highest magnitude here, are the social costs from disrupted lives and livelihoods and long-term well-being from this disruption or exacerbation of other conditions. The bulk of the costs that we see here, an estimated $810 million, is related to those social impacts that we see from these types of events. In addition, there are costs such as workers' compensation from illness and death for workers who are subjected to these really extremely hot conditions. In total, the financial consequences we estimated were at $870 million for a heat event in a single state. In this report, we also looked at how this might change if there were mass gatherings during a prolonged heat event. And in that scenario, the cost is even higher. It's about 920 million. And as we saw over the 4th of July holiday this year, those are of significant concern. One last thing I want to note before I hand it off is that the EPA estimates that the US can expect about 6 heat waves per year across the country in the largest metropolitan areas. So if we extrapolate our costs here to meet that estimate, we could be talking about over $5 billion in costs nationally. And even that is somewhat conservative in that it only looks at heat waves, not standalone high heat days, which we have many of during a summer. So with that, I think I'll stop and turn the mic over, but happy to answer any questions about the modeling at the end. Thanks.
Hey guys, I'm Paul Peterson, Director of the Preparedness Program with the Tennessee Department of Health. Really appreciate the opportunity to give you guys a perspective of a State Director of Preparedness in the public health space, and great timing on the release of the report. So just with all the events we've had across the U.S. with all the heat, and just note the impacts to other countries in Europe and the heat that they've been experiencing, how it can really overwhelm systems. So my goal, real quick, over these next 3 slides that I have, is to share with you just some really quick resources that may help different individuals plan for heat exposures and heat-related illnesses, and then some action steps, really some really practical things that people can take. Some of these will be kind of repetitive based on our different presenters, but it really wanted to kind of like set the tone that a lot of these different activities can be done in the preparedness space to reduce and mitigate the impact of these heat-related emergencies. And showing you the graphic that's on the screen is from our syndromic surveillance data in Tennessee, showing the hundreds of emergency department visits that we saw over a couple weeks time with this last heat wave. And it's important to note that the data that we have can inform preparedness actions, and it can inform things that we can do to better prepare our communities. And so that's really why data can be used for action, and not just as a dashboard. We need to look at what are those different steps that actually are triggers for us to move forward on things. And some of the biggest actions in my mind are, again, who is the most at risk? Uh, we talked a little bit already about, outdoor workers and those with chronic medical conditions. What are the triggers to opening cooling centers? Whose role is that in your jurisdiction? How can you collaborate in that space? Who is transporting individuals to those cooling centers? It's one thing to open them, but if people can't get to them, that's another challenge. Um, and then just, again, there's a lot in the messaging space. So how can we promote prevention steps so people stay more healthy? How do we get a better sense of the at-risk communities that may not even have air conditioning in their jurisdiction, where these events can really set them back? Um, and then are there other multidisciplinary groups that can help, or even nonprofits that can help with wellness checks and those kind of things in communities? Next slide, please. So my next point here is that, again, partnerships are needed. No single agency or organization can manage the health impacts of an extreme heat event. All of these things uh, are connected, and the emergency management landscape that we have across the U.S. is based on that. It is based on agencies, partners, private, nonprofit, all coming together to be able to leverage the resources that we have to take care of our communities. And in a heat response, it's no different. So we want to make sure that we have partners at the table. In the public health and healthcare space, we do have healthcare coalitions across the state and country that are again, a coalition of healthcare partners, public health, EMS, emergency management, and others that each bring both their resources, their expertise to the table, and can help identify gaps in planning. But then also when we're exercising and conducting responses, um, you know, bring that expertise to the table. Another resource federally that's available is the Emergency Prescription Assistance Program. Something to think about when we have large scale disasters that uh, either make people displaced from their homes, displaced from their medical home, or even their medications and their durable medical equipment. It's a resource for individuals to be able to get those medications if they don't have insurance. And so it's a little used resource that the federal government has through HHS, and wanted to highlight that as well. But a lot of the actions that we can take are associated with um, having a better understanding of what are the cascading impacts of an event like this. Who are all the individuals and systems that are going to be touched? And how do we prepare? And one of the ways we prepare is we do discussion-based exercises. We talk about the threats that could come up, identify the gaps, and then go back to the drawing board and figure out how to resolve some of those things. And that could be associated with communications planning. That could be cooling center gap analysis, getting a better understanding of sharing situational awareness during an event. All of those things will help us as a collective system to be able to better respond and support our communities. Next slide. And finally, I did want to focus a little bit on functional access needs populations. And in a heat event, there are going to be individuals that have less resources, are more medically fragile. And so there's a number of ways that we can better prepare those populations. by being really proactive in the preparedness space. And so some of the things that we've done in Tennessee are really trying to be inclusive in our planning processes and exercise design by bringing in different types of populations, functional access needs populations, to be able to make sure that their voice is heard. And so we've done that in a variety of ways. One is implementing the CMIST framework, which is trying to avoid labels and really focusing on what are the limitations an individual has. So communication, maintaining health, independence, safety and security, transportation, focusing on those 5 items and not necessarily labeling them with a disability. Another one, again, is telling stories and getting people involved in the process. And so we partnered with a number of agencies across our state, and there's a relatively recent article that was just published about it was nothing about us without us, and it's a telling story of how to better engage populations that need advocates. And so what we can do to better engage those groups and make sure that existing disability coalitions and other advocacy groups that are out there can really elevate and share messaging, especially when we're in dire straits in an emergency. And the big takeaway, is health equity is preparedness. The communities at greatest risk should be at the center of our planning and not an afterthought. So, and my big final kind of take home is, um, heat and forecasting of temperatures and all these types of scenarios tells us what's coming, but preparedness really determines what happens next. And so we all need to take that and move forward. I'll transition to the next speaker. Thank you.
Hey, great. Hi, everyone. And this has been an awesome webinar. Thank you for all the other great speakers. I'm Vicki Sakata. I am the Senior Medical Advisor for the Northwest Healthcare Response Network. Thank you so much to the Common Health Coalition and John Hopkins and everyone who has put so much work into this document. Certainly as timely as everybody has said. For those of you who know NWHRN, Honora Lean, our executive director, was supposed to be doing this presentation, and I am doing the impossible task of taking her place. So I'll give it a try, but please don't hold this against her at all, okay? So as you can see, NWHRN, for those of you who don't know us, we are the Healthcare Coalition for majority of Washington State, all that in blue and green. And like many of your states, we have a variety of different communities, urban, rural, and tribal as well. So next slide. And as Paul mentioned, when you talk about healthcare, it's not just public health and hospitals. There's such a variety and so many different people that have participate in making healthcare work and taking care of all of our patients. Excuse me. And I think the most important thing that I bring perspective that I've noticed being an ER physician and working clinically for over 20 years is that there's so many people that are involved, and there's nothing that will slow down a facility or grind a facility to a halt if EMS is not functioning, if long-term care is not able to accept patients, if home health is unable to do their jobs. I mean, all these players make an impact on any event that happens in healthcare when it comes to surge. And I will say one of the important points on this diagram here is the ancillary services. Speaking as a physician working in a facility, nothing will grind a facility to the halt the most as not enough housekeepers to prep rooms and get ready for the next patient. So everybody plays a role and everybody is important. Next slide. Those of us in the Pacific Northwest, we feel your pain. For those of you who've been on the East Coast and central US these past few days, heat waves, heat domes, they are miserable. And we in the Pacific Northwest had our own heat dome experience back in 2021. Um, and it's one of those situations where, there's always an impact. You can see what happened through the numbers of bullet points here on this slide. But the one thing that I draw your attention to is actually the last bullet. If you think about clinical medical surge as sort of a result of a heat wave experience, the surge during our heat dome did not actually occur until 2 to 3 days after the temperature started to rise. And if you review the literature on lots of heat experiences, extreme heat medical emergencies, this is often the case. It takes a while. Our body physiologically, as it is exposed to more and more heat, obviously it starts making compensation maneuvers. It compensates until it can no longer compensate, what we affectionately call in the clinical world falling off the Starling curve. And when that happens, then there's no going back and you need emergency participation and emergency help. But during our heat dome in 2021, we broke 128 all-time record temperatures. Seattle King County EMS. So King County is the largest county in Washington State with 2.5 million people. On average, on an average summer day, we usually get in King County about 600 EMS calls. During this heat dome on one day, we had 1,133 EMS calls in one 24-hour period, which set records from, shattered records since the inception of King County Medic 1. There's also, as you can see from the comments, we at NWHRN held sort of situational huddles during our heat dome experience, where we would get all the healthcare facilities on Zoom and provide situational awareness for everyone. And there were mornings where even first thing in the morning, there's 50 ambulances lined up waiting to unload patients. And this heat dome sat over the Pacific Northwest for several days. Go to the next slide, sorry. And also heat domes, as you know, increase mortality. And as you can see from the bottom slide, they had estimated post the event that there were 126 deaths related specifically to the heat dome. When you're doing a retrospective chart review, you can find those cases that are heat related. However, the most important point, next slide, advance, is that actually when you look at total deaths during that time, there was actually 440, almost 450 quote unquote excess deaths during that period, during that heat dome period. That was not attributed, as you all know, during 2021, there was actually another medical surge going on at that time. We were still in the middle of COVID-19 pandemic. So even if you take out the COVID-19 patients from this surge in deaths, there's still over almost 450 excess deaths during that heat period. And that's because there's secondary effects when you start adding heat to everything else. Next slide. And as was mentioned by Paul and several others, who is at most risk for this? And not only who is at most risk, but what can we do to actually help care for those who are at most risk? When you think about how our body manages excessive heat, as I mentioned before, we can compensate for a bit, but if we don't get relief, or if we don't get to somewhere where there is some cooling expectations, both the cardiovascular, pulmonary, renal systems, they all start to shut down. Our bodies are made, up to 65% of water. They are not made to handle boiling water. And so once these systems start shutting down, pretty much you can have total collapse of all your cardiovascular systems. And then you add things like dehydration on top of that. So a lot of our most vulnerable populations are ones with chronic diseases, as was mentioned before. So you take diabetics, for instance, if they're not keeping up with hydration and become dehydrated, as well as having the additional effects of heat, this can add to the catastrophe. Mental health and behavioral health, patients, also, they have a lot of medications that they're on that make them more sensitive to heat as well. And then I always like this effect called heat and. Heat doesn't necessarily always happen on its own. You have many heat events happen actually during wildfire season. So then not only do you have excessive heat, you have smoke that you're dealing with. And it can be smoke that comes from, I mean, in Washington State, we get smoke from Canada when there is wildfires going on there. So imagine if you're an asthmatic, you're in a heat extreme, a heat dome situation. You don't have air conditioning, and now you can't open the windows for as much of a breather that you can get because of the smoke. So this just increases the impact of heat. Heat and alcohol don't go well. Heat and alcohol and substance abuse does not go well. The ability to really understand where you are physiologically and call for help when needed is diminished. And so that increases your risk. Heat drives everybody outside. So there's accidents, drownings. During our heat dome, we actually had 7 drownings in one day, which was twice normal average for that time of year. So there are, these secondary effects from heat. And we've already mentioned the elderly. Really in your heat planning, don't forget long-term care facilities and the elderly patients. And, as we all know, our population in the US is growing older. So they always need to have extra considerations as well. And as was mentioned, there were utility outages. There can be utility outages, which did occur during the Seattle heat dome. Fortunately, it didn't affect healthcare as much. But CT scans go out, other healthcare equipment, if there's electric outages or not enough generator support, that can really become problematic when you're trying to manage a medical surge. Next slide. And I would say in general, in the last closing comments, I really love this document that was part of the briefing. Every medical surge. This document actually just doesn't apply to heat itself. Every medical surge has domino effects. There was already mentioned the fact that we can manage medical surge by canceling elective surgeries. We have found through COVID that really nothing is elective, and if you cancel certain things, you're putting other people at risk as well in their own personal health journey as well. So there are domino effects throughout this. There's also just patient consequences and health consequences. In every surge, you need to make sure that you have enough space, staff, and stuff. I mean, if you get an increased number of patients, you need to be able to take care of them. And it comes to a point where all of that has a cost. And I would touch specifically on staffing. You can drive your staff to take extra hours to manage a 4 or 5 day surge, as we saw in COVID. When the surge happens over years, that is really impossible to ask your staff to do that. And also it's a cost. So even in a 4 or 5 day surge, if you don't have enough staff, you're paying overtime for staff. You're all of a sudden needing travelers to come in, which is also an additional cost. So all of this has a domino effect and increases healthcare costs in general. So next slide. We should all be familiar, those of us who do disaster response, we're all familiar with this sort of sequence of disaster management cycle. We try to prepare and mitigate, but then there's response and recovery, and it comes in a cycle. And just as Paul was mentioning, there is some good news in all of this. So next slide. I think when we think about heat in general, there's so much that we can do in preparedness and mitigation that really we should be thinking about heat in preparedness and mitigation so that we can make our communities, provide resources for our communities, and make them more resilient to heat. Because as we all know, this sort of situation is really not going away. And as I mentioned previously, or maybe I didn't mention, it's very unusual for Washington State to have a heat event. And in our after actions, this is what's causing us in Washington State to really focus on mitigation and preparedness. So immediately after our heat dome effect, heat was never even in our HVAs. So heat is now part of our planning processes and procedures. And Seattle just got finished hosting 6 World Cup games, and we've been preparing for this for the past year and a half. And every meeting I went to, every committee that was preparing for a FIFA World Cup mentioned heat, and we all pulled out our heat plans. There were already pre-positioned places for cooling centers and messaging in many languages and reaching out to our most vulnerable populations. This all needs to be part of planning and heat, and we can do so much in planning and mitigation that actually we can alleviate a lot of the response needs. And one of my most important mottos in disaster preparedness is that the best part of disaster preparedness is actually trying to prevent the disaster in the first place. So let us work together. And it takes a village. It takes a village outside of just healthcare and public health. It takes a village to create communities who can be resilient to heat. And I would propose that this is a challenge to all of us to really take this into consideration. And I believe that's it for me. So I probably talked too long as usual. I'm sorry. Go back to Common Health Coalition, Chelsea, Crystal, back to you.
Thanks, Vicki. I want to remind folks that there's a Q&A box, so please put your questions there. For audience questions, we have a few questions for the panelists that I'll start with, and then I'll hand it over to Chelsea for the audience questions. I guess I wanted to start out with kind of the big picture. So, a theme of this report is that heat is not just an environmental issue, it's a health issue, it's a health systems issue, it's an economic issue, it's a community resilience issue, it affects housing, transportation. How can we break down these silos? I think probably Vicki and Paul, this is a question for you. What are some joint activities, investments that we can be making across our agencies and our health systems? Go ahead, Paul. You were quicker on the mute button.
We'll probably echo each other a little bit. Again, it's all about making the relationships before the disaster, and that is investing in the preparedness planning cycle and the whole, emergency management system that we work within, in emergency support function 8 or health and medical. And we have to exercise these things. We have to identify gaps. And if we stay in our little silos of excellence, we're gonna fail. So we have to be able to communicate across industries.
Absolutely. Well put. And I would just say that one of the reasons, I actually moved from clinical work to working with a healthcare coalition is because I see the extreme benefit of having multiple partners in one place, sitting at one table to solve the same problem. And so this is really, heat is one thing that we need multiple partners at the table. You need to identify gaps, and you need to bring everybody at the table to try and solve the problem. And amazing things can be done with that.
Thank you. On that theme of coordination and cross-agency work, I'm curious if either of you are seeing new challenges or new responsibilities for your roles as the federal government's policies are changing and their capacities are changing. How has that affected your preparedness for this season?
I'll tread on this gently. I think the challenges that we experience kind of in the public health and healthcare sector right now is uncertainty. And without investments in public health and healthcare preparedness, we put ourselves at risk of taking a step back and losing capabilities and being less resilient for that next big bad thing. And so, I think we can all probably sing from the rooftops the needs that we have, but continued prioritization of this space is really important to make sure that we can take care of our communities.
Vicki, do you have something to add there?
Well, I would just add that, what we just finished speaking on to the previous question is that we need to all be at the same table. We all need to work together. And that does not happen freely. That does not happen without a cost. And if we are going to close these gaps and if we are going to take care, especially of our most vulnerable populations, we need to make the investment there. And I think that is really one of the most important takeaways from all this. We need a village, but the village doesn't come free.
And I might add too, as a former Fed who worked on a lot of emergencies, I was always very keenly aware of how the federal agencies needed to coordinate, and ways that we could be more and less helpful in interacting with state and locals when they were handling emergencies. So I think, that the turnover in staff, the reduction in staff, even without resource changes, is something that has concerned me about how states will experience federal support in emergencies. And I know that puts more pressure on you all as state leaders, and is one of the reasons why we wanted to actually highlight this issue. Crystal, for you, I wondered, this was a really interesting scenario model, and I wondered if there was anything that surprised you in doing the modeling work, about the methods or the findings, or what data were and weren't available.
Yeah. So I think what surprised us was how pervasive the impacts were. I know we've all thought about this before, but going through systematically and trying to identify them was really enlightening. Thinking about all of the kinds of people and businesses and systems that an emergency touches. And so I think that's reflected in the results and the kind of magnitude of the results, and also echoed in the heat wave that we've just been through over the holiday weekend. And so not that we wanted to see that, but it was really reinforcing to see how that played out over the holidays. And I think we were thinking about having these mass gatherings. Obviously, Vicki, you've been dealing with major mass gatherings in Seattle, and we think that's a significant part of this. And we saw clearly that if we're not preparing well for those, don't have sufficient resources, it's an add-on to things that preparedness and response personnel are doing all the time, and it can really have an impact on people if we're not ready.
I'm going to ask one final question and then hand it to Chelsea to take the audience questions. But this is for everyone, and Chelsea, I include you in my list of everyone. If we reconvened 5 years from now, what progress would you hope we would have made in heat preparedness specifically and emergency preparedness writ large? Let's start with Paul.
I think the biggest thing is making sure we've learned from lessons of the past. And there's many different events that we've just have talked about through the various presenters. And if we don't leverage those things to strengthen our preparedness, then we're going to miss out. And so, the biggest thing that we can do that I'm really passionate about, again, is investing in our coalitions, making sure that these public and private partnerships are reinforced. We need each other to respond. We cannot do these things together, or we can't do these things separately. We have to do them together. And that's my big take home right there.
Vicki?
Yeah, no, there's a large wish list, but it all starts with what Paul just said, is like getting people to the table to work together. I mean, we need to build more resilient communities in general to face a lot of disasters that potentially are coming our way. But specifically for heat, you even need to think outside of even healthcare. I mean, urban planners need to plan our urban cities a little bit better. We need better building. I mean, in Seattle, really, we have so many old apartment buildings and even new apartment buildings that are going up without air conditioning. I mean, that sort of needs to change. So we need to put we need to plant trees, not cut them down. We need shaded areas. I mean, like, so I'm saying that this is for heat, there's so many other partners that need to get involved, and a community needs to be committed in general. It's specifically in healthcare, we just need to be always prepared to manage heat effects. I think a lot of times it catches even clinicians off guard because we don't see it very often. So keeping that education up at a med student, nursing student, getting them aware of these concerns. Education is very key to that, to building a resilient healthcare community as well.
Yeah, and something that I've learned a lot about in doing this is we think a lot about effects on hospitals and clinics, but primary care really gets overwhelmed during these surges as well. And I don't think it's easy to account for that in the ways that we model. So maybe, Crystal, I'll ask you, where would you like to see us in 5 years?
Yeah, maybe I'll go up one level. I really want to see steady funding and adequate funding for preparedness and response, including our cooperative agreements, FEP and HPP, and also support for community health worker capacity. I think an investment in communities and cultivating leaders who are also connected to healthcare and public health, who can identify most vulnerable individuals in our communities and know how to help them when there's an emergency. So I think that's what I would like to see.
Chelsea, let's close out our 5-year wish list with you, and then I'll hand you the mic for the Q&A from the audience.
Thanks, Deb. I want to make sure we have your 5-year wish list. I think mine is a hope that we mobilize these lessons learned, right? This is not magic. This is not mystery. We know what works. We know that deploying and really embracing community health workers before a crisis strikes works. We know that investing in infrastructure for preparedness works. We know that programs like Get Cool in New York City, or the Oregon, support for air conditioning through their Medicaid program. We know these work. This is not a mystery. And so at this point, if we aren't deploying these types of programs that get us out of our silos, that get us working together, sharing data, sharing plans, but really embrace what has worked in the past, then that's a choice that we as a system are making. It's a matter of will, not way. And so I think that if we get to 5 years from now and nothing has changed, that's on us, but also something will have changed, and it will not be for the better, and it will not be in service of the people and the communities that we all serve. It will be to their disservice if we don't take these lessons and mobilize them.
So the only thing I would add, Chelsea, because I think we have a very similar idea of what needs to happen, is I really would love to see state leaders who can work across these systems and can say, hey, there's a Medicaid solution. Hey, there's a population health solution. There's a health system solution. There's a regulatory solution. There's a transportation solution. And so how do we get attention? This is always hard for things that haven't happened yet, or get people to pay attention to the last bad thing that happened. And that gap in between emergencies is really hard to capitalize on. So I'm hopeful that folks on this call are going to be able to help us do that.
Honestly, Deb, you're teeing me up perfectly for this audience question. And Vicki and Paul, I'll let you two tag team this. Okay, we're in this place. There was just this massive heat dome wave on the East Coast. I think everyone here acknowledges that this will happen again. TBD where and when, but it will happen again. If you had a wish list for these, however many days, weeks, months that we have, weeks probably, in between this event and the next one somewhere in the US, what do you wish, or what do you want? And we don't need to wish here. What would you prescribe that health leaders, so both on the health system side, on the healthcare system side, and public health, state and local, are doing in this span of time where we actually have some time to get ready for the next one? Vicki, you want to kick off?
Sorry, I'm having problems finding the mute button. After years of being on Zoom, you think I could find the mute button. Oh yeah, there's a large list. I think Paul will probably have a lot of the public health
Great.
lists to explain. But from a healthcare perspective, any kind of medical surge, you need communication between partners. So in the in between times, if you don't have a system set up so that you can level load. For instance, during our heat dome, there was a few hospitals that just happened to be in communities that had bigger effects and were overwhelmed, while other facilities were not. Um, we know from COVID that level loading saves lives. So you need to have a system in place where you have some sort of central, what we call a MOC, Medical Operations Coordination Center, that will help with level loading. That is a valuable resource in any kind of medical surge, But for heat in particular, we always say there should be cooling centers. Well, let me tell you, a cooling center takes a lot of work to put together. First of all, where is the cooling center going to be? Are we just going to volunteer the closest shopping mall to be a cooling center? They may not want that. So there's a lot of groundwork that has to go into place to identify the cooling centers. And as someone mentions, if the vulnerable people that need a cooling center don't speak English, then your messaging needs to be correct. You need trusted resources within these communities that will help them get the need that they need so desperately. So having all that in place, different languages, all the logistics set up for cooling centers, having some backup systems for 911, as you saw with our numbers, you're going to have triple the number of EMS calls in one day, and you have to take care of your own staff. The EMS folks needed to go out of service and in service more frequently because they were experiencing heat exhaustion as well. So all those need to be part of your planning. I could go on, but Paul, turn it over to you.
Yeah, I would echo some of the things that you said too. In the kind of situational awareness realm, making sure that we have a good understanding of what healthcare facility has what resource available. And so we've done that kind of reporting for years. We're just getting to the space where we're starting to automate those processes using national standards. And so, getting that implemented will help free up folks at the healthcare facilities to report. Um, you know, Better understanding where our vulnerable populations live, where they are at, and working with community groups to better serve their needs, I think is also a critical thing that we have to do. And a lot of that work is already ongoing, but we have to really raise that voice. And the final thing is just really stressing personal preparedness. Folks that have the resources, they need to be more resilient. They need to look out for their neighbors. We need to kind of reinvigorate that kind of feel of the volunteer spirit. Being from Tennessee, or Tennessee Volunteers, we want to get people, amped up to be able to take care of their community. And, government and healthcare, we can't do that alone. We have to rely on our communities to take some of that initiative, and we can meet them where they're at.
Thanks, Paul. You actually answered another question in the chat, which was around what people can do around personal responsibility and preparedness. And I think that answer was perfect. And for the health system leaders on the call, communicating what those steps are and, doing more public communications and engagement and community-based engagement with CBO partners on how people can prepare for these, particularly in parts of the country where, like we know how to do this in Louisiana. Others are not as well versed on it elsewhere if they're not as used to these heat events. So thank you for those comments. Okay, we're going to take one last question. I think there are a couple questions that actually circle around the same issue, which is around changes at the federal level or budget changes, leadership and budget changes at the federal level. How do we address heat-related illness and preparedness amidst potential cuts to funding at the federal and state levels in this environment, and what remains important to focus on regardless.
I'm happy to kick
Go
that
ahead, Deb, you
off.
kick it off. Yeah.
I want to say two things. One is in the public health space, the HPP grant, the FEP grant that Crystal mentioned, those have not been cut. They have been proposed to be cut, but I think anyone on this webinar should expect that Congress will not cut those programs. I think it is problematic that they keep getting proposed for cuts, but we've not seen Congress actually follow those recommendations. So I'm hoping that funding is more stable, and that's what we saw last year, and that's what we've seen in both the House and Senate marks for this year. I think there were some potential preparedness cuts in the House mark. So that should resolve soon, but I think the bigger issue in the federal funding has been in NOAA and FEMA and how stable that funding will be. And then, of course, with HR 1 changing access to healthcare overall, people may be coming into these events sicker or without access and the ability to prepare with a clinician.
Perfect. Vicki or Paul, anything to add there? Because I know we are just running up on time.
I think Deb nailed it.
Wonderful, per usual. All right. Well, with 1 minute to spare, I'm going to give everyone a quick round, rapid fire round for Vicki, Crystal, and Paul. One thing that you want folks to take away from either this report or this webinar that they can do today. I'm seeing faces of like, you didn't prepare us for this. Vicki, we'll start because you're off mute.
Oh, yeah, I will just jump in and repeat what has been said before, but and I was looking through the questions too. Thank you, Arizona. This is what we need, what Arizona just offered and said, they face heat all the time. Come to us. We'll share our information. That is what we need. And we need collaboration within our state to get people to improve their preparedness. But we also need to talk to states that have this experience and really learn from each other. So I would say if there's one thing to take away from this, you go back and you identify those partners that you can learn from or partners that you can help. And let's get our communities to be more resilient. Thanks.
Paul, go for it.
Yeah, preparedness doesn't happen on accident. We all have a role. And so we have to be able to prioritize both the funding resources, our personnel resources, and our community resources towards these types of threats. I think Vicki and others have said, this heat emergency threat paradigm isn't going away. We are likely going to see more of this. And in the South, that means flooding after a heat event. And so again, all these cascading things, we have to be prepared, and we have to think more broadly. A lot of the time, we can apply kind of a global emergency management approach to these types of threats and be successful. And so continuing to invest in those partnerships is critical in my eyes, but then also, again, looking at those functional access needs populations as well and making sure their needs are met.
All right, Crystal, last word.
Okay, I'll make it quick. CDC has said that almost all of these illnesses and deaths are preventable. And so I think wonderful to have Paul and Vicki on here to talk about how we can do that. But I think this is something we can work towards. It's not inevitable.
Thank you. Thank you all. I think that's it. We'll see you soon. Okay, bye.
So much, y'all.